I think the starting point is just to try to discuss how do we assess the risk of the disease in AML in general. Because if we rely only on the classification, on the genetic classification, we have some sort of scholastic division between low risk and high risk patients. Generally speaking, AML could always be high risk. So in this trial, what we did was for the so-called intermediate risk patients, was try to assess the post-consolidation strategy based on a dynamic risk assessment, which was based not only on the baseline classification using the NCCN 2009 that was available at the time, but implementing with the addition of MRD. So basically for the intermediate risk patient, who are some sort of gray zone when we still do not know what to do after consolidation, is to assess MRD at the end of consolidation using flow cytometry, and then deliver them to autologous in case of MRD negativity, so some sort of intermediate lower risk patient. And on the other hand, give allogeneic transplantation to those patients that had MRD positivity, so were more similar to high-risk patients. And what we found at the 2 years follow-up is that for MRD negative patients in the intermediate risk category that was submitted to autologous had the same outcome of patients that were submitted to allogeneic because they were MRD positive. And we wanted to confirm this data with an updated 6-year follow-up. And this is basically what we found. So we may conclude that in general, we have to integrate MRD and dynamic risk assessment after consolidation, so for patients in remission. So this gives us a better idea on how we should intensify or de-escalate treatment.